Okay, so we were looking at the different structures of the filtration membrane. The filtration membrane, if you recall, is part of this corpuscle, which is like the area where we have the capillaries derived from the afferent arteriole, and this is where we filtrate our plasma. So if you magnify this, you can see that the membrane, the filtration membrane, is made by the wall of the capillaries, the glomeruli, the basal lamina, and the visceral part of the capsule of Bowman. So this visceral layer has these cells, which are the podocytes. If you magnify this region, you can see here the extensions of the podocytes, which are the pedicels. And then here you have the basal lamina, and then you have your capillary wall, which is made of simple squamous epithelium. And then we said that we have fenestrations in this epithelium, and of course inside here we have the red blood cells, white blood cells, plasma, and whatever ions and other things we have in the plasma. So through these fenestrations and high pressure that happens, because you have the efferent arteriole that it is narrower than the afferent, you have buildup of pressure that leads to force of fluids, and also these molecules through these fenestrations. And then you have these filtration slits that happens between these pedicels. It's like if you have like inner chelation between your fingers, and then you can open and close this so that you can allow the passage of molecules, larger and smaller. Now, there is this specific space which is around 7 nanometers, and then you have negative charges here within this space that prevents cells to come out into this space, and also proteins. So you have to keep proteins in your blood vessels. These proteins help to maintain blood pressure because that will keep a specific volume. So this is called oncotic pressure, the pressure that pulls fluid into your capillaries, while the capillary hydrostatic pressure will be the pressure that forces molecules out. And something that you can see here is that, of course, since this is a membrane that is intact, it doesn't have any injuries, you keep your cells and your fragments like platelets inside the blood vessel while small molecules and water is filtrated. So that's the importance of having healthy glomeruli. Keep large molecules inside the circulatory system, and then keep large molecules inside the circulatory system, and the small molecules that need to be filtrated goes out into this space. And there is a measure of filtration that's called glomerular filtration rate that tells you the efficacy of filtration by the kidneys. Typically, the filtrate that is formed, it's about 125 milliliters per minute, or around 180 liters of filtrate per day. So, why we don't urinate 180 liters per day if that's what we put into the filtrate? Well, it's because most of this filtrate, we reabsorb it. And we end up urinating like around 1.5 liters of urine per day. So your entire plasma volume is filtered 60 times per day. And that requires this pressure gradient that we talk about. So again, it's a play between the diameter of the afferent and the efferent arteriole. The afferent, the arriving arteriole is wider, the efferent is smaller in diameter. That increases the pressure. And then we have hydrostatic pressure gradient, and then colloid osmotic pressure gradients. And then you have something that is called net filtration, that it is taken by, or well, that is calculated based on the differences between the hydrostatic pressure, the oncotic pressure, but not only from the glomerulus, but also from the glomerular space. Of course, or the capsular space, sorry. In the capsular space, we shouldn't have any proteins, but we have fluid because it's not dry. So that fluid, try to force fluid into these capillaries, into the glomerulus, but it's not as great as the one that we have inside the glomerulus. So that's why the fluid tends to go from the glomerulus into this space. So the glomerular hydrostatic pressure, GFP, it is determined by your systemic blood pressure. Typically, it is around 50 millimeters of mercury. And then again, it is related to the, as well, to the diameter of this efferent and the afferent arteriole. And then the glomerular colloid osmotic pressure, which is the pressure given by the proteins, it is around 30 millimeters of mercury. That is what tries to pull the fluid from the capsular space into the glomerulus, and that is less than the capillary hydrostatic pressure. So what brings in the fluids and what brings them out? So the one that brings it in is 30, the one that brings it out is 50. So there is a gradient, so we have 20 millimeters of mercury of difference, and that makes the fluid go out into the capsular space. And if you put into account the 10 millimeters of mercury that we have in the capsule space for hydrostatic pressure, so if you sum these two, like the glomerular the glomerular colloid osmotic pressure, or GCOP, which is 30, plus the CHP, which stands for capsular hydrostatic pressure, 30 plus 10, how much it is? 40. And then if you subtract 40 from 50, that gives you an NFP, net filtration pressure, of 10 millimeters of mercury. So that is basically what drives fluid outside of the glomeruli to go into the capsular space, and that's what gives you the filtrate. So here is the illustration. So you have your afferent arteriole that brings blood into this glomeruli, and then the blood exits through this efferent arteriole. As this diameter is less than this, you have building up of pressure in here. And this glomeruli is surrounded by the glomerular capsule, or the capsule of Bowman. And in between this glomerulus and the capsule of Bowman, you have the space. And then if you magnify this part of the filtration membrane, you can see the different forces, like you have the fluid inside your capillaries, which is GHP, glomerular hydrostatic pressure, which is 50. And then you have your proteins, like your albumin, your globulins, that are inside your capillary. That is that glomerular colloid osmotic pressure, or oncotic pressure. This is 30. That's what pulls the liquid in. And then you have in your capsule fluid, which is creating a pressure of 10 millimeters of mercury. So this is capsular hydrostatic pressure. So two forces pull in fluid into the capillary, while one forces the fluid outside of the capillary. Since 50 minus 30 minus 10 gives you 10, you have more force towards the capsular space than towards the glomeruli, and thus you're supposed to have filtration. Think about a bank account. Okay, so let's say that this is where you have money exiting, $50, and then you earn 30, and then another 10, so that gives you in a deficit. So you have $10 that you have to pay. So that's your net filtration pressure. And then we already mentioned before about what happens with damage to this membrane, glomerulonephritis. It can happen for different reasons, including infections, or sometimes antibodies lodged in your glomerulus. So you can have an excessive leaky filtration membrane that can lead to the loss of cells and protein, and that can lead the person to have accumulation of fluid in the interstitial fluid because, interstitial space, because the oncotic pressure that is given by the proteins is lost, because your proteins will go into your urine, and this is known as proteinuria, and this is not good. And then we already talked about this mechanism for regulating your GFR, which is the myogenic mechanism that takes seconds. This is related to the stretch of the muscle cells around these arterioles in relationship to your blood volume. So you can have less stretch or more depending on how much blood volume you have. So for instance, when you have a decrease in your blood pressure, you have less stretch, that will decrease your GFR. And when you have increasing blood pressure, that increases your stretch, that increases your GFR, and then you lose more fluid because you filtrate more. And when you have low blood pressure, there is no purpose for losing fluid. So, and then you have autoregulation by feedback between your glomerulus and your tubules. So of course, when you have increased GFR, more filtrate will go into your tubules, so you will have more tubular fluid, and then you will have more sodium and chloride delivered into your macula densa cells that they are going to send a signal to increase the release of this molecule that is going to decrease the GFR. And then all of these, again, is related to your blood pressure. So if your blood pressure increases to 180 millimeters of mercury, your urine output will increase. And if it's below 70, you'll have, of course, anuria. So, decrease in the diameter of your afferent will lead to less blood coming into your glomerulus. When you have less blood coming into your glomerulus, you have decrease of the hydrostatic pressure that will decrease your GFR. Opposite, when you have increased blood volume, you have more hydrostatic pressure that increases your glomerular filtration rate. And then if you have vasodilation in your afferent arteriole, that increases your glomerular hydrostatic pressure because you will have more blood coming in, and that increases your GFR. Now, what happened with your afferent if the diameter of the afferent doesn't change? Well, in this case, you will have more blood coming out than what comes in a way. That will decrease your hydrostatic pressure, that decreases your GFR. And then we saw before the renin-angiotensin-aldosterone system, in which you will convert this angiotensin into angiotensin 1 by this enzyme, angiotensin converting enzyme in your lungs, and that will be a powerful vasoconstrictor, the angiotensin 2, that is going to lead to the increase of the blood pressure, and it's going to stimulate the release of aldosterone by your adrenal gland. And that aldosterone is going to promote the absorption of sodium and chloride. So this is what is called a salt-retaining hormone, and that is going to pull water from your kidneys, so that will increase blood volume and blood pressure. And if you have ADH present, you will have as well more retention of water. Everything, it depends on when it's necessary to have more than aldosterone present to absorb more fluid. If you have very low blood volume, of course, you will have to definitely release ADH. You have to secure that you have enough blood volume. And then along with this, to increase blood pressure, you will stimulate your thirst mechanism so that you will intake more water, and that will help to maintain GFR. We saw this cascade. Where does angiotensinogen is produced? In the liver. So this is a precursor of this protein, and is broken down, this polypeptide, into the active precursor by renin, which is released by the kidneys when you have lower blood pressure, and then angiotensin 1 goes into your lungs, and then you will have angiotensin 2, and then that will lead to all these processes that I explained that can lead to the increase of blood pressure. And then we have AMP, urinary peptide. It's called an urinary peptide because it's released by the atria, the right atrium, the heart of the wall of the right atrium. And then we have natriuresis, which is basically urinating sodium. This happens when you have an increase in blood volume that dilates your atria, but also, of course, whenever you have increase in blood volume, that is going to dilate your afferent arterioles, and that increases the GFR because you have more blood to be filtrated. And now, some people have chronically active this RAS system, and the person will have hypertension. So with this hypertension, of course, the person will have risk of having a stroke, for instance, and then you have to control these hypertensions. And then you give drugs which are inhibitors of the enzyme that converts angiotensin 1 into angiotensin 2. So these are angiotensin converting enzyme inhibitors. Sometimes these drugs, they end up in the suffix "il", like enalapril, captopril drugs. And then we have as well angiotensin receptor blockers that can control the blood pressure, or antagonistic drugs for aldosterone that can cause mild diuresis. Okay, and now let's talk about renal failure. So, renal failure is a condition in which your kidneys are not able to eliminate wastes. And this happens for several reasons. No matter what is the reason, you have a decreased glomerular filtration rate. And based on timing, you can subdivide your renal failure into acute or chronic. Acute is happening typically among hospitalized patients, and they can be resolved without any treatment, while chronic, the person will have GFR that is decreased from 3 months or longer, and causes for this can be diabetes or hypertension, and the person, since it won't be able to eliminate these wastes, will have accumulation of urea, uric acid, nitrogenous wastes, ammonia, and it has to have basically dialysis. Increase of nitrogenous wastes in the bloodstream is called azotemia. And then signs and symptoms of this problem is fatigue, edema, nausea, loss of appetite. And then sometimes the person, if it's not treated properly, can have coma, seizures, and death. We have 2 types of dialysis, hemodialysis and peritoneal dialysis. In hemodialysis, you have temporary remove of these metabolic wastes and extra fluid, and you'll have this dialysis done in a clinic 2 times a week. And then in peritoneal dialysis, you have this treatment that it is performed at home nightly, and you have a machine that is helping you to get rid of these wastes that is connected into the peritoneal cavity in the abdomen. Something that happened during the pandemic is that many patients that had COVID-19 developed acute kidney injury, like 25% of the patients who were hospitalized with this virus that caused the COVID-19. And it is not known how that happened, but likely the mechanism of injury is through immune-related reactions or inflammatory reactions that affected the renal tubules and the epithelium of the glomeruli. Okay, now for tubular reabsorption and secretion. So reabsorption again is reclaiming whatever the cells, our body needs. So in this filtrate goes not only wastes and excess of ions, but also it can go nutrients like glucose, amino acids. And of course, you don't want glucose to go in your urine because bacteria, they like to grow in a media that is rich in glucose. So glucose and other nutrients, they have to be reabsorbed. So out of these 180 liters of filtrate that we form per day, we reabsorb 99%. So we end up with around 1.5, 2 liters in urine. And then we do so within these tubular segments. So the area where we reabsorb the most is the PCT. That's where we have these cuboidal cells with a lot of microvilli. But we still do so in the loop of Henle and as well in the DCT, and sometimes even in the collecting ducts. So that's a process of reabsorption. And then in tubular secretion, we basically get rid of anything that we don't need. So that's mostly done at the DCT, and as well in the collecting duct. And especially we control the levels of hydrogen in these areas because it's necessary for us to have a specific pH so that our cells can work properly with that concentration of hydrogen ions. Now, in order to perform these processes of reabsorption and secretion, we have something that is called paracellular and transcellular routes. So in paracellular route, the substances pass between adjacent tubule cells. Like, for instance, you have the passage of small ions, water, in the PCT, and you don't require ATP with the paracellular route. In the transcellular route, you bring through the cells, passing through the apical side into the basal side, molecules like glucose and amino acids. And some of these are co-transported, and you require ATP. So transcellular route is an active process, while paracellular route is a passive process because you don't require ATP. Okay, so now, if you magnify this part in here, you can see this proximal tubule, and then you have here this peritubular capillary. And then if you magnify these two parts together, you can see here this peritubular capillary, the basal side of these cells of this proximal convoluted tubule, and then the interstitial space. So we have two routes. This one, which is the paracellular, so in between the cells, or the transcellular, which is crossing these cells. And then when substances come from the lumen, so from here to here, from the lumen of the tubule, no matter if it's paracellular or transcellular, when it goes into your capillaries, this is reabsorption. And when the substances goes from the blood into the cells and then into the lumen, this is secretion. So if you remember, for transport of molecules in our cells, we have carrier-mediated and facilitated diffusion. So facilitated diffusion, you have a protein that is specific for that molecule, and then the molecules will move from high concentration to low concentration, or from more to less. And then you have primary active transport, like a pump, where you use ATP to move molecules against their concentration gradient, so from less to more. And then you have secondary transport, which is set up by a primary active transport pump, and it is used to drive the transport of a second molecule against its concentration gradient. So carrying two molecules in opposite directions is done by antiport pumps or antiporters. If you carry the two molecules in the same direction, will be done by symporters. And then something to keep in mind is that we have specific carriers, and then we have a limited number of carriers. So sometimes you can saturate these carriers and then you reach a maximum transport. It's like if someone is going to give you more than two heavy objects and tells you, carry it all at once, but it's too heavy and bulky, and it gives you three, how many can you carry? The person gives you three objects, they're heavy and bulky, and tells you, carry them all at once. Can you do it? No. How many can you carry out of the three? Two. So that's what we have with saturation. So we have a finite number of channels that can carry a specific molecule. So that's when you reach your maximum transport, when you just can bring them in at specific numbers. And that basically, it explains why sometimes people will have glycosuria, or glucose in urine. So if you have too much glucose in the filtrate, you can just reabsorb a certain amount and the rest will be carried into the filtrate, into the tubular fluid. And that's what happens with diabetics and also with pregnant women. It's a physiological glucosuria because you oversaturate your carriers of glucose. And then polyuria. It is when you have extra glucose molecules in your filtrate and that pulls more water and then you urinate more. That happened to diabetics. And this is called as osmotic diuresis. So then what is the cause? Well, hyperglycemia, excess of glucose in the blood. That leads to polyuria and then glucosuria. And not only that, the person will be thirsty because he's losing a lot of water through urine. So there is the triad of the polys for diabetics. They have polyuria because they urinate a lot. They have polydipsia because they have to drink a lot of water to compensate by the loss of urine, or sorry, fluids in their urine. And they have polyphagia, they eat a lot. Okay, so that's a triad of the polys. Okay, specific roles for PCT. Reabsorption of electrolytes like sodium, chloride, potassium, sulfate, and phosphate. Reabsorbs nearly 100% of the nutrients, including glucose, amino acids, vitamins, and lactic acid. Reabsorption of bicarbonate ions, and reabsorbs 65% of the water. Remember, this is where we have most of the microvilli, and secretes hydrogen ions, nitrogenous wastes, and certain drugs. And when it comes to sodium, we have symporters of sodium. Like we have the sodium glucose symporter. And then we have antiporters like sodium and hydrogen ions. So hydrogen ions goes into the lumen while you absorb sodium. And then in the cytosol, the sodium concentration is about 12 millismoles, but in the filtrate, it is 142 millismoles. So the concentration gradient is very large. And then we have reabsorption of organic molecules. We already said about the glucose, which is in sodium, but we also have other molecules like amino acids, of course, that typically they are reabsorbing there. And one of the things that we shouldn't lose at all is proteins, including amino acids in our urine. So here is the process of glucose reabsorption in the PCT. So if you magnify here, you can see the cells are cuboidal with microvilli. This is the microvilli. So if you have in your filtrate ions like sodium, in this case the purple dots, and then you have glucose, which is like these hexagons with green color, you have in the microvilli sodium glucose cotransporters. So you bring them together, and then you will have exchange of sodium here in the basal part for potassium. So you have the sodium potassium pump. And then glucose diffuse, and then you have a carrier protein here, and then it goes into your bloodstream. In this area, you have high concentration of sodium. Why? Because you pump it in here, and then sodium also will be coming into your bloodstream. When it comes to bicarbonate, ion reabsorption, so you have the same formula for the formation of these as you did when you saw this in the respiratory system. So you have CO2 plus water, which is going to form carbonic acid by this enzyme, carbonic anhydrase. And this carbonic acid can be broken down by the same enzyme into water and bicarbonate. So if you see these two arrows pointing in both directions, meaning that reaction can go both ways. And then this carbonic acid, by the same enzyme, carbonic anhydrase, is going to be broken down into hydrogen ions and bicarbonate. So when you have excess of hydrogen in your bloodstream, you will make this reaction going in this direction, so you can eliminate hydrogen ions, and then you will have bicarbonate that can quench the excess of hydrogen and forming carbonic acid, and then going in this direction so that you form water and CO2, so you can exhale CO2. So hydrogen ions are secreted in these cells into the filtrate. And then you combine them to form this carbonic acid, and then you do this process of forming this bicarbonate. So this is the reaction in this area. Again, we're talking about the PCT. So here you have your peritubular capillaries, the interstitial fluid, your simple cuboidal cells of the epithelium of this tubule, the PCT, and you will have this carbon dioxide being reabsorbed from their filtrate, combined with water to form carbonic acid, and then this carbonic acid is going to be broken down by this carbonic anhydrase into hydrogen and then into bicarbonate. Bicarbonate is going to be absorbed into the interstitial fluid and then into the peritubular capillary. It's going to be exchanged with sodium in here. But then see how bicarbonate will enter here into your bloodstream, and if you have excess of hydrogen ions in here, you will have the same reaction. So you will absorb these hydrogen ions with this bicarbonate in here. Now, what will happen with this hydrogen? Well, this hydrogen is going to be extruded in exchange for sodium, because you have this sodium hydrogen ion transporter. And now, here, if you have bicarbonate in your filtrate, you will do the same reaction, but outside of these cells. So something that we said that happens in here is that you reabsorb water, 65% of water, and this is called obligatory water reabsorption. And by the time that the filtrate has reached this second part or second half of the proximal tubule, you have glucose, organic compounds, and many sodium ions that already has been reabsorbed. So then water will be drawn out of the filtrate by osmosis. So since you already pre-absorbed these molecules, then you have water there, and this is called obligatory water reabsorption. And then you have these specific channels for water, which are the aquaporins, that enhances this water reabsorption. So after you have absorbed all these solutes before, in the second half of your PCT, you have water, and then you have aquaporins in this microvilli, and water will be absorbed and then transferred into the interstitial fluid and then into the bloodstream. That's obligatory water reabsorption. And then for secretion, we partially seen it before with hydrogen ions, but also we secrete nitrogenous wastes, and then one of these will be ammonium, and then we also secrete uric acid, which, if you remember, it's a waste product of nucleic acid metabolism or catabolism. And then you can also secrete here creatinine, which is part of this metabolism of muscle, and the less toxic form of nitrogenous waste, which is urea. Some drugs like penicillin, morphine can be secreted here, and then will be lost in the renal secretion. Okay, so now for the loop. So in the loop, you have reabsorption. So in the PCT, you already reabsorb 60 to 70% of the electrolytes and water. And most of these organic molecules or solutes have been already been present. And then when this this tubular fluid goes into your loop, about 20% of the water and 25% of your sodium chloride will be reabsorbed and returned. So pretty much in here, in this area, that's where you will finalize most of the absorption, but that doesn't mean that you cannot do more. That will depend on what is the needs of the body in terms of all of these molecules. So this is done majorly because you will have changes in osmolarity in the interstitial fluid. So in the interstitial fluid, typically you have an osmolarity of 300 milliosmoles. And then you have this loop of Henle that goes down and then goes up, and then you have different permeabilities based on the changes on the osmolarity. So something that happens in that thin descending limb. So you have freely permeable to water, but less to solutes. So water will move out here by osmosis, and if some solutes will move, will be very few. So as you move into this descending limb, the osmolarity of the filtrate increases because you keep reabsorbing water that concentrates more the filtrate, and then it will reach then the loop itself, and then you go moving this fluid into the ascending limb, which is totally impermeable to water. So in here, you will transport sodium chloride, and then you have some importers like sodium and potassium chloride importers that brings 1 sodium and 1 potassium and 2 chloride ions into the tubule. So that's where you change a lot of the concentration gradient of sodium. And then the filtrate loses solutes and becomes less concentrated. So up to this point, you have 85 to 90% of the sodium being reabsorbed, and then the rest will enter and go into the distal convoluted tubule, where you have same epithelium, cuboidal, simple cuboidal, but with less microvilli. And then the rate of filtration is going to be slower. So instead of having high filtration rate, in here you have about 20 millimeters of filtrate being processed versus the proximal convoluted tubule, which is having 120 millimeters per minute. So this is like less efficient, but you have less still things to process there because you mostly have 90% of the work done. And then what it happens in here, in the distal tubule, is that you secrete many things that they weren't secreted before. Because the body, what it does is even sometimes some of the wastes, they reabsorb them in the PCT, and sometimes it's just going back into the filtrate or going to the tubular fluid at the DCT because it's really not needed to have them there, these wastes. So something that we have in the distal tubule and in the cortical part of the collecting ducts is that we have some hormone receptors for aldosterone and ADH. And then with these ones, we can absorb more water if it's needed, like when someone is dehydrating or when someone has a hemorrhage. And the water absorption in this area is called facultative water reabsorption because water reabsorbs according to the need. Facultative is flexible. If you don't need, you eliminate it. If you need it, you reabsorb it. So we have then one of these hormones, aldosterone, that transcribes aquaporins. So this hormone goes and binds into the DNA of these cells and makes the cells to make aquaporins. And these aquaporins goes and inserts into these cells and makes the water to be reabsorbed. And then also you increase the permeability for sodium. And then you increase the number of sodium potassium pumps along the way. Now, we also have the action of ADH, which is made by the hypothalamus and released by the posterior pituitary gland. So this one causes the aquaporins to be inserted into the membranes of the cells of the DCT, and then you will have more reabsorption of water, and antidiuresis tells you what it does. Basically, it prevents a person from urinating when the person needs the volume to be in the circulatory system rather than of course, in urine. And then, just in case, we also have atrial natriuretic peptide. So this one, again, it is released not when someone needs fluid. It's actually when someone has excess of fluid because you have more return of blood into your right atrium that stays in the right atrium, and that's when you release it. And then that is going to be an antagonistic hormone for ADH and aldosterone. So let's say that aldosterone and ADH help the person to normalize its blood volume. So then you release ANP so that you don't have more ADH and aldosterone. So you don't want to have excess of fluid. And then at the same time, you not only lost water, but also sodium. And the same hormones act on the medullary collecting system, but more is going to be ADH. Now, one way to control hypertension is by giving diuretic drugs. So a diuretic drug is something that increases the loss of water so prevents the reabsorption of this water, increases the urine output. So we have something that's called the loop diuretics that inhibits the sodium potassium chloride channels in the ascending loop, and that will decrease the water reabsorption. And then we have the thiazide diuretics that targets the sodium ion transporter in the DCT, blocking the reabsorption of sodium. And then since you don't reabsorb sodium, then you don't reabsorb water. And then we have some diuretics that makes like the thiazide diuretics that can unfortunately have an indirect effect on potassium secretion. So a person will lose water but can lose also potassium, and that is not good for the body. So we have some types of diuretics that are called potassium sparing diuretics, and then this prevents the loss of this potassium. And then we have some that are called triamterene that block some channels in the cells of the collecting system. So not only in the loop, you can have diuretics, but also in the collecting system, and that prevents the potassium ion secretion, and sometimes is paired with a thiazide diuretic. So sometimes you can have problems with the secretion of hormones, and that affects the blood volume and the formation of urine. So ADH, antidiuretic hormone, it is produced in the hypothalamus, released by the pituitary gland, and helps for the absorption of water and preventing urination. If someone has a stroke in the hypothalamus, in the area where you produce the ADH, you might not produce ADH. And this is what we call the syndrome of inappropriate ADH secretion, of SIDH. So this SIDH can lead to excessive fluid retention, and that leads to decreased plasma osmolarity. So the plasma will be overly dilute. And you can have high urine osmolarity, in which your urine is going to be overly concentrated. So this can be treated with typically antagonistics of this hormone, and then the person won't have as much problems. Now, how the tubular reabsorption secretion maintain acid-base balance? So if your pH blood decreases, so if you have acidosis, you have excess of hydrogen ions, you will have enzymes in your tubular cells that remove from your proteins amino groups. That helps for the generation of ammonia molecules and two bicarbonate ions, and ammonia will be secreted and the bicarbonate ions will be reabsorbed. And at the same time, you will have hydrogen ions being excreted and then also be combined with ammonium, and then the person will have the pH back to normal. Now, what if it's the opposite? What if your pH in your blood increases? What if you have alkaline or lack of hydrogen ions? So in this case, you have your cells in your tubule reabsorbing less bicarbonate, and you will retain hydrogen. So that's like what happens in these tubules. Okay, now for the osmolarity of the filtrate. So the filtrate that enters into your renal tubule typically is osmotic with the plasma. In our plasma we have 300 milliosmoles, so it's the same as the one that we have in this tubule. So as your renal tubule receives this tubular fluid, it will change this osmolarity based on where it's located. So in the thin descending limb, your filtrate will concentrate until it reaches the bottom of the loop. So from 300 will go up to 900, but will be in longer loops up to 1200 milliosmoles, because you are concentrating as you are reabsorbing water in the descending limb. You can concentrate your tubular fluid more. And then as you move this fluid from the loop up, you will have gradual decrease in the osmolarity. So from 1200 will go to 900, 800, etc., until where you reach the part that is next to this distal convoluted tubule. You can have around 300 or sometimes a little bit less than 300 milliosmoles. And this is done because you have this exchange again of water and solids within the loop, and because you have changes in the interstitial fluid as well as you move all of these ions around. So something that will happen is, like, if you have very little water reabsorbed, so your concentration of your filtrate will lead to the production of diluted urine, so less than 300 milliosmoles per liter. When does this can happen? Well, maybe you have a hormonal problem, or maybe you are overly drinking water. Now, what if you don't drink as much water? In this case, you will reabsorb as much water as possible, and you will develop concentrated urine with a concentration greater than 300 milliosmoles. So here is the changes of this osmolarity. So in your corpuscle, you have 300 milliosmoles of the filtrate. When the filtrate moves into this PCT, which is going to be now called tubular fluid, here you have 200 milliosmoles. So it's still the same as here. So it's isosmotic. And then as you go down in the descending loop of Henle, you reabsorb water. So this tubular fluid becomes more concentrated. 300, 550, 750, 900, 1200 if the loop of Henle is longer. And then as you move up, you don't reabsorb water, but you reabsorb sodium chloride. Then your tubular fluid becomes less concentrated. So from 900, 550, 250, 150, 100 in here. And then you keep reabsorbing in this DCT sodium chloride. And then you end up with, in this case, for diluted urine, like if you were drinking a lot of water, you will have less concentration of urine. So facultative water reabsorption happens in the last portion of your distal tubule when someone needs water and the person is dehydrating. So we have the example of what happens in this facultative water reabsorption. So if you have two vessels nearby or tubules, so you will have this flow of fluids inside these vessels or these tubules in opposite directions. The one that has more in this, let's say, heat, like if you have two blood vessels together, this one that is having more blood supply, circulating more blood, increases the heat because of the friction in here, and then this one has less, so you have transfer of heat more in this direction and in this direction. So we have counter current mechanisms in the nephron loop that helps for the concentration of these molecules in these vasa recta from the juxtamedullary nephrons. That it's a little bit different from the cortical nephrons, and that helps to concentrate more the urine just in case that is needed, because you might have more ions in one of these blood vessels than in the other one, and then you can exchange. So that's like the multiplier effect that we call. And then something that you can see here within these loops is that, of course, this is the ascending part, this is the ascending part, and since this ascending part is impermeable to water, but it is permeable to sodium and chloride, and since this one, it is only permeable to water, of course, as you have more sodium chloride will exit in here, and this is the interstitial space, and then this sodium chloride is going to pull the water from this area, concentrating the urine. And then this water ultimately will go into your blood vessels. So something that you can take out from this place is that, from this part, is that sodium chloride is actively transported from the filtrate into the, in the thick ascending limb into the interstitial fluid, raising this sodium chloride concentration, and then that basically increases the osmolarity of your interstitial fluid, and that will lead to the absorption of more water, of course. And that increases as it approaches at the bottom of the loop in this area. So that's for water and for ions, but again, we have as well some waste products like urea that also can be reabsorbed. And in this case, that urea will follow a concentration gradient. So it will diffuse into the interstitial fluid and then enters into the descending limb of the nephron to rejoin the filtrate. So it's like a recycling process. So this is the complete picture. So we have then this filtrate that it goes into the tubular, into the tubules of the nephron, that it changes its osmolarity from low to high and from high to low. And as it's doing that, you will have differential absorption of items like water in here, sodium chloride in here, and that changes the osmolarity as well of the interstitial fluid. So you start here from low concentration or low osmolarity to high concentration in this bottom part, given by all these ions like sodium chloride and as well by the solutes, like in the case of urea. And then this is a juxtamedullary nephron. So this one is the one that is close to the medulla. So this is the medulla, this is the vasa recta. And then this one will have an increased osmolarity in this region that affects as well the osmolarity of the vasa recta. So it's going to be, of course, similar to whatever you have in the interstitial fluid, but ultimately, as you go up and down, that will lead to the absorption of water or secretion of items according to what is needed, and that is what is going to regulate ultimately the concentration of urine. So this type of neurons with this kind of current exchange between the ascending limb of the loop of Henle and the descending limb of the vasa recta, or the ascending limb of the vasa recta and the descending loop of Henle, that's what it concentrates the urine. So these ones are the ones that concentrate the urine. So what, as a summary, what concentrates the urine? The osmotic gradient between the filtrate, interstitial fluid, and the presence of hormones like ADH, the countercurrent mechanism, and you have a concentration that can be up to 1200 milliosmoles at its higher point. Okay, so we will leave it up to here. Do you have any questions?